Good afternoon, everyone. Welcome to our Pediatric and Adult Endocrinology Grand Rounds here on January 22nd. Today, I have the pleasure of introducing Dr. Emily Montgomery. Dr. Montgomery attended University of South Florida and St. George's University School of Medicine in Granada. Followed by a pediatric residency right here at the University of Louisville, and we were fortunate enough to have her join us in fellowship. She completed her fellowship in 2024, where we were able to lure her onto the faculty. So it's been fantastic having her join us as a new faculty member. Her area of interest really has been in the realm of diabetes. She's particularly interested in beta cell survival and regeneration and replacement. And it's no wonder that she is the perfect speaker today to teach us more about type 3C diabetes. And so, Dr. Montgomery, thank you very much and welcome everyone.
Thank you for a very kind introduction. It's my honor to be here for so many years and to stay on as faculty, and for all of you to be here with me as we talk about type 3C diabetes. As soon as I can figure out the technology of moving this, I will get started. Okay, cool. So we're going to talk about type 3C diabetes. This is just a disclosure slide. The objectives, we're briefly going to talk about what is type 3C diabetes, what are the different etiologies of this type of diabetes, how should we be screening, what are the treatments that we can be providing, and then what are the newer things coming out, what are the new treatments and places we're headed, and also some options for prevention. So type 3C actually just refers to pancreatic diabetes. It got that name because in the ADA table, there were 4 broad types, and in the outline, it was 3, and then .C was the diabetes that was secondary to pancreas derived destruction, and that has stuck, so it keeps its name of type 3C diabetes. Essentially, this type of diabetes occurs when the islets are destroyed by a primary pancreatic disorder. So different than type 1, which is an autoimmune disease, right, that is specific to the islet cells and the endocrine dysfunction. Different from type 2, where we see that insulin resistance and that demand for a higher production of insulin to manage our glycemic control. This is actually a destruction of the acinar tissue and the exocrine pancreas that bleeds over into destroying the endocrine cells. This represents about 5 to 10% of all diabetes. There's some debate, is that really the number? Is it higher than that? There's a lot of overlap where people are typically diagnosed with type 2 diabetes despite having underlying pancreatic disorders. So probably we're missing a few of those people. It is interesting to know almost all of the causes of type 3C diabetes, because it is actual destruction across the board of the exocrine and endocrine pancreas. It's different that we lose alpha cells the same way we lose beta cells, right? So in type 1 and type 2, we see a lot more of insulin-derived issues where we don't have sufficient insulin or we can't manage to make enough insulin to keep up. But in this situation, we actually also see a loss of glucagon. So you're missing that counter-regulatory response. It's a lot harder to get to tight glycemic control because your risk of hypoglycemia, of severe hypoglycemia, is very high. So when we look at, so if you know me, you know I love pathology and all of these kinds of things. So I'm going to nerd out for a second if you will come with me. So this is our typical way that the pancreas is laid out, right? So we have our islet here that has our different endocrine cells, our alpha, beta, gamma, delta. And then they're kind of laid out in this nice circle. We have some innervation here. We have some blood vessels that are shared across the board. Then we have some acinar tissue. So they're bound a little bit differently, and they all have the duct that comes into them. Then we have our ductal epithelial cells that line the ducts. And this is kind of how we get our enzymes that go into digestion, and all of our exocrine function is kind of delineated that way. So we know alpha cells make glucagon, right? That's a response to drop in blood sugar. This stimulates glucose synthesis from the liver and mobilizes that into the bloodstream. Increase in blood glucose leads to beta cell releasing insulin. For the obvious reason, we want to get the glucose into the cell so that we can make energy. The delta cells release somatostatin, which can both inhibit insulin and glucagon release. I learned last week at a conference that actually the lack of delta cells and somatostatin can, because you're not ever inhibiting glucagon release, not having it can also prevent you from being able to release glucagon in addition, because the glucagon cell never gets to kind of like reset. Fun fact. And then the gamma cell, or the pancreatic polypeptide cell, plays a role in releasing pancreatic polypeptide, which has to do with a lot of insulin sensitivity in the liver. So this is a very different picture, right? Here we see like happy, healthy little tree. We have ducts that go into these acinar cells, and we have this very nice islet that looks very pretty and happy. Oh, same here. This is our nice, pretty islet. This is a duct cell. You can see it's not very fibrosed. It's nice and clear. And then these are the acinar tissue. This is our regular functioning exocrine tissue. This does not look like that, right? So we can see here that the duct is pretty plugged with different kinds of debris and inflammation. So this is preventing the enzymes that were being made by these cells from getting out of the duct into the GI tract, which also leads to a lot of destruction of these cells, right? If you're making enzymes and not able to get rid of them, that typically can lead to autodigestion of the pancreas and exocrine tissue, which leads to loss of function. Some inflammation that comes along, which are these purple little cells, and then a lot of fibrosis that replaces the fatty tissue that's kind of taken over for the loss of cells. And then you can see our islet cells don't look very happy. There's a lot of fibrosis going on. There's some inflammatory infiltration, and then there's just a lot of kind of destruction within here. Our blood cells are also not looking quite as happy with the ducts here. And then we can see it here. So when we look up here, this is a lot of fibrosis that's taking place. So this is actually a chronic pancreatitis picture, and this is a cystic fibrosis picture. And you can see that they're actually pretty significantly different. There are islet cells still present in both of these. These islet cells look much prettier and still much happier and intact. These are smaller and have a lot of fibrosis surrounding, right? So you can see that a lot of this tissue has been destroyed and no longer exists at all. There's a lot of different fibrosis that's taken place here. Your extracellular membranes don't look very nice, and your acinar tissue is very much atrophied. Here we just see a lot of fatty replacement. This is so all of these like empty circles. This is all adipose tissue, and that's what's replaced the acinar cell tissue. So you're not getting as good of exocrine function, but the way that this destruction occurred is very different. So in CF, we typically see like islands of islet cells that have survived in the surrounding like fat tissue. Versus in chronic pancreatitis, the destruction is kind of very widespread and is not as islet sparing. So obviously right down here, we lose glucagon response, hypoglycemia, loss of insulin response leads to hyperglycemia, and then hepatic insulin resistance with impaired gluconeogenesis is not a great recipe for success. So how do we actually get the pancreatic diabetes? Clearly, chronic pancreatitis creates an issue because we just looked at that and cystic fibrosis. But there are a few other things that some are less common, but actually also have a pretty significant effect on the glycemic control and cause diabetes. So we have cystic fibrosis. We'll talk about hemochromatosis and other forms of iron overload disorders, pancreatitis, ductal adenocarcinoma, agenesis, and then removing part of the pancreas can also cause diabetes. So when we look at cystic fibrosis, I think we're all probably pretty familiar with pediatric and adult patients that have CF and CFRD. So we have that loss of the chloride transport channel, right? So because of this, we get a dysregulation and an ineffective transport, which leads to a lot of increased viscosity, which creates problems in the lungs and the sinuses, but also creates problems with the ducts. This leads to obstruction of the ducts, kind of like we saw in the pictures before, which leads to that fatty replacement of acinar tissue and overall pancreatic insufficiency. And so if you're destroying the cells surrounding, you're also going to get some destruction of the beta cells and the alpha cells and the islets that are all distributed within that tissue. So while this is the best recognized cause of type 3C diabetes, it actually accounts for the least amount of this type of diabetes, which is kind of interesting. It is not common in young children. As they age into adulthood, it becomes more common. So 20% of our adolescents that have CF develop diabetes and 50% of our adults. The risk increases 10% with each decade. The genotype, obviously, if you have a much more severe genotype that leads to more severe symptoms and dysfunction, you're going to be more likely to develop beta cell and islet cell destruction. Decreased lung function and female sex are all associated with increased risk of diabetes. And then a diagnosis of CFRD is associated with worsening pulmonary function, poor nutritional status, and increased mortality. Clinically, typically they're young, they're not obese. Insulin deficiency is their primary defect. We don't see signs of insulin resistance, and we don't see features of metabolic syndrome. Fasting blood sugar is actually often normal. Their initial loss is in their early phase of insulin response, so their first phase, and it's typically seen in the postprandial state. And so this actually affects the way that we screen for diabetes in our CF patients. So the mechanism, we looked at this earlier, right? So basically, as the pancreas is breaking down, the insulin production and secretion also is breaking down because the islet cells are not being able to survive. There is some direct effect with the mutation on the CFTR gene on the beta cell's ability to secrete insulin, so they are also targeted a little bit more. but you typically don't lose all of the islet cells. So some of them are still surviving, typically not enough of them to manage glycemic control in the way that the body demands and for sufficient anabolic metabolism, but there's enough typically that these patients don't develop DKA and ketosis. They also do have a decrease in alpha cell mass because of the type of destruction, but they don't always, they can still manage a response to hypoglycemia. And then they have some hepatic and peripheral insulin resistance related to inflammation and infections, but not related to the same metabolic dysfunction we see in patients with type 2. So in these patients, fasting blood sugars and A1Cs would fail to detect diabetes in 50% of patients that have cystic fibrosis. So these are not recommended, which is clearly different than most of the ways that we diagnose diabetes. So we actually look at OGTTs for these patients. And the other thing that is different is that you don't have to be well. You can be on continuous feed, and you have to have certain intervals of screening, right? So if they're having an exacerbation, if they continue to have persistent elevation in their postprandials, that qualifies them. If you are on continuous enteral feeds and you are having persistent elevation in the same way, they also qualify. If you have CF and you do not have a diagnosis with plans for a transplant procedure and you've not been screened in 6 months, you need to be screened preoperatively and then monitored very closely afterwards. The same with pregnancy. Should you have a plan for pregnancy or confirmed pregnancy and you've not been screened in the last 6 months and you do not have a diagnosis of diabetes, you should be screened for CFRD with a 2-hour fasting OGTT before they do like gestational diabetes, right? Because we would like to ideally separate a CFRD diagnosis that pre-exists the pregnancy to separate that from a gestational diabetes. Regardless of if you pass the OGTT looking for CFRD, you do need additional screening for gestational diabetes at 12 to 16 and 24 to 28 weeks. If you do develop gestational diabetes, it does not cross over to your postpartum period, so you're not considered to have CFRD, and you do need additional testing to be repeated at 6 to 12 weeks postpartum. So that I think is extra interesting because in the rest of the population outside of pregnancy with gestational, if you meet the criteria one time, regardless of whether you have resolution of your hyperglycemia and issues with glycemic control, you are considered to still have CFRD. So like once you have that diagnosis, it doesn't go back away, which is interesting because if you develop gestational diabetes and have CF, that diagnosis does go away and you go back to your screening for CFRD. So we talked about this already. It's the same kind of thing. So 2-hour blood sugar on your OGTT has to be 200 or greater. You can, if you meet the criteria for a fasting or an A1C, you can get the diagnosis of CFRD, but those are not useful because that 50% of people would not have diabetes if we use that criteria. Does that make sense? Kind of wordy back and forth. So you can still make the diagnosis. You can screen during acute illness, but you can also make a diagnosis during acute illness during overnight feeds. And then we talked about screening after gestational diabetes. So treatment for CFRD it's insulin driven, right? So one of our biggest issues is our lack of nutrition, our malabsorption, right? We don't have good weight gain. We also are losing a lot of protein. Our pulmonary function is clearly not ideal. So by using insulin, we lead to that anabolic state, right? So now we're promoting nutrient retention, weight gain, improvement in our weight, also leads to the ability to make proteins and muscle, and then improves our pulmonary function and survival. It also helps us, obviously, with our immune system to overcome infection if we have better nutrition and function. Their goal, A1C, is the same as their peers with diabetes, which is less than 7, and then oral diabetes agents are not effective because really what you need is the replacement of insulin for that anabolism, not because you need like improvement in insulin resistance and other features. So complications are not all the same as our typical diabetes. They are at risk for microvascular, but they're not as much at risk of macrovascular because they really don't have issues with like high cholesterol levels. We're trying to get their nutrition to be like an appropriate status. We're not trying to bring down their nutritional. So I think that's probably obvious within this, but they really don't have the issue with like atherosclerosis. They do have the issues that come directly from hyperglycemia long-term. Yep. So insulin deficiency obviously leads to a worsened state in general because it's a higher rates of hyperglycemia lead to an increase in growth of infections and also a loss of protein and fat, which decreases your ability to fight infection as well. So there has been some really cool stuff that has come out with the drugs that we use to treat CF. So ivacaftor and the triple therapy both have shown improvement in the development of diabetes in patients that have CF. And Trikafta has actually shown that if they started after the development of diabetes, they have resolution and improvement in blood glucose control, which is pretty sweet. Because you also haven't lost all of your beta cells, right? You do still have some islets that are still functioning. The dual modulator therapy, though, did not show the same effect, and so the tri is much better. So hemochromatosis, right? So this is a disorder of excessive iron storage, which accumulates into several different organs and then leads to destruction, right? So there is an autosomal recessive form, primarily of which affects the HFE gene and is seen most often in the Northern European population. This leads to your classic like triad of bronze diabetes. So you have diabetes, increased skin pigmentation, and hepatomegaly. You can also have liver cirrhosis, cardiomyopathy, hypothyroidism, and hypogonadism. Fun fact that 80%, there's a study that came out that showed that 80% of the French competitive athletes who won Olympic, Euro championships, and national championships all were heterozygous for the HFE mutation. So they had just enough to help out like their hemoglobin and their iron stores, but not enough to cause disease. So like it could make you a really good athlete if you have just one. And it's actually come out that it's pretty common across the board for all super competitive successful athletes. So, and the secondary causes are not as cool. So these often occur in patients who have had a lot of packed cell transfusions, but have not had iron chelation. So they also are accumulating iron in the same places. So how do you get diabetes in this group of people? So this actually accounts for more diabetes than CF does. And I have never seen this in my life, and I see a lot of CFRD, but also in pediatrics. So like, I'm sure that there's a little bit of difference there. There has been a dramatic decrease in the diabetes occurring in hemochromatosis because there has been a big push to identify and screen with genetic testing to prevent the development of a lot of these complications by treating early. And so by recognizing and starting treatment ahead of time, they actually don't develop diabetes because they don't have the iron deposition in the pancreas and don't lead to disease. They're typically the people that do develop diabetes are ones that have had severe iron load and cirrhosis, at which point that becomes permanent. You cannot go backwards once you have cirrhosis. As far as the mechanism, so this is different than all the other forms of pancreatic diabetes. The alpha cells and the gamma cells are actually not affected. The beta cells are specifically targeted by the hemosiderin and iron deposition, there's some specifics relating to transporters and receptors. And so the iron overload actually specifically causes beta cell damage, and you lose the ability to produce insulin in response. So you don't have the same degree of severe hypoglycemic risk, and you also still are able to improve some of your insulin sensitivity as far as alpha and gamma cells go. However, the degree of hepatic damage does relate to insulin resistance in a different way. And this is true for all people who have iron overload from any different etiology. So the screening is kind of interesting. There's not a lot that really gives specifics about when people should be screened and how we should screen them. We know that screening for hemochromatosis in the high-risk populations is very heavily recommended. And by treating these patients with phlebotomy, we are improving the rate at which people are developing diabetes. When to screen for impaired glucose tolerance in these patients is not clear. So it's known that if you have liver cirrhosis, your diabetes will not go away. And so it definitely needs to be treated. So probably if you're developing pretty severe liver dysfunction, we should be monitoring your glucose tolerance pretty closely. If you have a family history of diabetes, whether or not it is in diabetes related to iron overload, you have an increased risk of developing that in this setting. And then the details are not very clear, but I think if you're having progression of disease, it's probably obvious we should be making sure that that's not part of your progression. And then if you have a high family risk, we should probably be watching closely. There is an interesting backwards thing where they did several studies, looked at people who had all been diagnosed with type 2, and then went looking for HFE mutations to see if there were people who had hemochromatosis that was not diagnosed, that was actually causing diabetes, because if they didn't have cirrhosis yet, there was an opportunity to improve some of their beta cell function and glycemic control, but they did not find very many. So we're not missing a whole lot of them. Most of them are being appropriately diagnosed. And the diagnosis is based on your typical ADA criteria. So treatment, the best treatment is prevention by phlebotomy to prevent iron overload. So phlebotomy in people who have hemochromatosis, and then iron chelation in people who are getting frequent transfusions. Treatment is insulin, right? We're not really having major issues with the other etiologies, and the insulin resistance is related to like liver failure. So probably insulin sensitivity that is derived from liver changes is not going to be particularly helpful. Early initiation is preferred. And then also you should avoid consuming raw shellfish because these patients have a high rate or risk of septicemia secondary to Vibrio vulnificus. So complications are very similar to the rest of our patients with diabetes. So micro and macrovascular complications exist. So pancreatitis. I feel like the adults probably are more familiar and see this a lot more than we do, but we do see it a little bit. So the etiologies are a little bit driven by the age of the patient, right? So chronic alcohol use is clearly more common in adults than in children that have pancreatitis. Disorders of the duct flow, right? So when we looked at those diagrams, we saw that like clogging the ducts and creating distension and problems there leads to much faster and more aggressive destruction. The tropical calcific pancreatitis, which occurs primarily in an East Asian region, hereditary pancreatitis, there's a very small proportion of autoimmune pancreatitis, and then idiopathic. There are three kind of different breakdowns within pancreatitis. So we have acute, recurrent, and chronic. Acute is just like a rapid onset of severe destruction and fibrosis of the acinar tissue. There have actually been cases of people who do develop diabetes from a single acute episode of pancreatitis or a single known acute episode of pancreatitis, but it's certainly not as common as those who have had repetitive damage, right? So your acute recurrent that typically leads to chronic, we have these episodes of repeat injury and double plugging and get this ongoing inflammation and destruction of the tissue. As far as globally, chronic pancreatitis is about 33.7 per 100,000 person years, but has some different rates of incidence and prevalence depending on where you are and how common the different types are. So post-pancreatitis diabetes. So less than 10% of these patients are children. So about 4 to 9% of children that have these develop diabetes, 26 to 80%, which is a very wide range, but is very consistent in all of the literature for adults who have acute, recurrent, and chronic. And then almost 80% of type 3C diabetes is actually due to pancreatitis. So your risk of developing pancreatitis is very much related to how destructive the underlying disease is and how long you have had it, right? The longer you've had a super destructive disease, the more likely that the tissue has been destroyed and that you're going to lose function there. The fibrocalculus of tropical pancreatitis is also high up there. Hereditary chronic pancreatitis has the highest rate of diabetes development, with 60 to 70% of people developing diabetes. The median age of onset is about 38 to 53-ish, somewhere around 50. And then, the more often that this trauma happens, the more destructive it happens, the more frequent it happens, the higher the rate of islet cell dysfunction and hyperglycemia will be. So the mechanism in this case affects all of the cell lines of the islet cells. So we lose our ability to secrete insulin. We also lose our ability to secrete glucagon, and we lose our pancreatic polypeptide, which leads to some increased insulin resistance from the liver. We also have a lot of nutrient malabsorption, right? If we've had the degree of destruction of the exocrine pancreas that we've gotten to this level of islet cell dysfunction and destruction, we have already lost a lot of our exocrine function and our ability to absorb nutrition and the enzymes that we need in our gut. And so there is a need, one, for us to treat that so that the general absorption can improve, but also by improving the state of nutrition, we can also improve some of the incretin secretion, which helps with some of the insulin release of the remaining beta cells. So there is a special set of criteria for post-pancreatitis diabetes. It was put out by Ewald and Bretzler. It applies to some groups of type 3C, but it doesn't apply to everyone. So I kind of put it here because obviously, like, not everybody has absent polypeptide secretion based on the etiology of their diabetes from the pancreatic destruction. So they have the same ADA criteria, and then you have to have exocrine insufficiency. You have to have imaging that shows that you have some kind of pathologic pancreatitis, and then you cannot have type 1 associated antibodies, because you certainly could have type 1 diabetes and pancreatitis, right? It's not mutually exclusive. So we would put you in your type 1 category and not type 3C if you have antibodies. And then minor criteria are really just evidence of the destruction of the pancreas leading to the development of diabetes. So your absence of the rest of the islet cell functions, the lack of insulin resistance, and then the malabsorption of lipids and the low level of those ADEK. So how do we treat this? Primarily, we treat this with insulin because that's our major loss, and also because most of the oral meds that exist to treat diabetes outside of insulin either have a risk of pancreatitis, which seems like it's not a great idea, or they're contraindicated in pancreatitis, which is also not ideal. Or the third option is that they cause worsening of the symptoms that you already have that are causing you problems with pancreatitis. So those are pretty much off of the table, and we typically stick to insulin. While everyone that's on insulin needs glucagon, these people really need glucagon, right? Their risk of severe hypoglycemic events is very high when we lose that ability to produce glucagon and that counterregulatory response. They need pancreatic enzyme replacements, right? So we need to address our maldigestion and malabsorption, control our symptoms, and then improve incretin secretion, which helps to improve the function of the beta cells that do remain. And then my favorite that I think is super interesting is the total pancreatectomy with islet autotransplantation, which involves a block removal of the pancreas, the spleen, the duodenum, and sometimes the gallbladder with a Roux-en-Y, and then the isolation of islets and reintroduction, which we'll talk about in a little bit. So who do we screen? How do we screen? So the ADA actually recommends that once you've had an episode of acute pancreatitis, you are getting screened for life. So you get screened once, 3 to 6 months after your episode of pancreatitis, and then every year after that. You can screen with A1C and fasting glucose in these patients, which you cannot do in CF, right? And then in those with chronic pancreatitis, they should be at least screened on a yearly basis, more frequently if you're starting to see symptoms or any changes. And if either of these is abnormal, then you go for an OGTT. As far as complications, they are more similar to that of CF in the way that they are primarily microvascular. Your macrovascular is very specific and more related to some malabsorption and vitamin deficiencies relating to foot ulcers and lower extremity arterial disease. But these patients also have issues with fat malabsorption, et cetera. So they are not at risk for the same fat, like cholesterol-related macrovascular atherosclerosis. So briefly about pancreatic agenesis. So this is a congenital malformation where you either don't develop any of the dorsal pancreas or you develop part of it. 50% of these people develop hyperglycemia and diabetes. You can also have several other physical structural issues, right, relating to bile duct obstruction, abdominal pain, which seems obvious with bile duct obstruction and pancreatitis. There are 3 genes that are specifically discussed. There have been like 54 cases reported between 1911 and 2010. So this is not super common and probably was missed a lot in the earlier times before we had a lot of imaging as well. But PDX1, PTF1A, and then GATA6 are the 3 well-associated genetic causes of the dorsal agent. So pancreatic ductal adenocarcinoma. So this is a cancer that occurs in the duct of the pancreas. The global incidence is 8.1 per 100,000 person years. This is the most common type of pancreatic cancer and is also very aggressive with a very high mortality rate of a 5-year survival rate of less than 10%. This accounts for 8% of cases of type 3C diabetes. So when we look here, it's a little bit smaller, but we're looking primarily, this is like the duct tissue here, right? It's normal. We see like a little bit of some extracellular matrix. Things look pretty clean and well distributed. And then here, this looks like a lot of chaos, right? So the duct is completely blocked. This is the tumor cells. We have inflammation. We have a lot of fibrosis and some different processes taking place. And one looks like it's very functional and clean, and one looks like it's very much not functioning and having a lot of destruction, right? So there is a very interesting bidirectional association with diabetes in ductal adenocarcinoma. So essentially, we know that obesity and type 2 diabetes can be risk factors for people to develop this adenocarcinoma because their high rate of insulin production leads to growth and tumor survival and proliferation in that area. And then there's a bidirectional blood flow in the pancreas, which provides this mechanism of developing these or delivering these high levels of insulin to the tumor cells to create this like proliferation and survival, and then also bringing a lot of the transcription factors from the tumor cells to the beta cells, which then creates this paraneoplastic effect of destruction or dysfunction of the beta cells. So you get this like bidirectional, and there's a little bit of like chicken or egg. However, there also have been studies that have shown that when you take out the tumor, a lot of times the glycemic instability goes away. So there's clearly a paraneoplastic effect. However, it doesn't mean that you couldn't have had diabetes before that also made the tumor grow more from a different etiology, right? There's also some recommendation to screen for pancreatic cancer and other pancreatic origin of diabetes when we're seeing patients who are presenting with a pretty significant weight loss that far exceeds the severity we would expect based on the glycemic control that they're presenting with. That they don't present with, metabolic dysfunction. They're not obese. They're not having evidence of insulin resistance. That should trigger us to do a little bit more workup. And there's actually recommendation to do imaging to make sure that there's not a pancreatitis or other pancreatic etiology as well as cancer. And because there is a very high rate of people who are diagnosed with diabetes less than 24 months before they're diagnosed with adenocarcinoma. So it's clearly a preceding event if it is caused by the paraneoplastic effect of the tumor and the beta cell. And that is, if the earlier we catch pancreatic cancer, the better we are able to treat it, right? And most people don't get diagnosed until they're further along, which is part of the issue with the mortality. So the mechanism is interesting in that there's some increase in insulin secretion, which affects some of that paraneoplastic, and the fact that we have been able to resolve this in patients who had new onset diabetes in the setting of that 24 months prior to the diagnosis, when they removed the tumor, as long as there was still pancreas tissue left, right? You have to have some islets that are functioning that remain. These people, for the most part, all had resolution of their diabetes. People who had long-standing diabetes before the diagnosis did not see that change. There is a little bit of question of okay, yes, but you also did a Roux-en-Y, which is pretty significant bariatric surgery, right? And we do see some improvement in glycemic control of people who are status post Roux-en-Y. And that's true, but most of these patients are presenting with significant weight loss and other things where they're not having the same level of metabolic dysfunction that we would anticipate bariatric surgery would be so dramatically helpful for glycemic control, right? So the treatment here is a little bit different, right? The treatment idea, really the goal is what can we do to improve their glycemic control sufficiently that they will tolerate treatment for their cancer and surgery. And then there's a very poor survival. So we really don't know very much about complications long-term because nobody really survives to a long-term period where we are able to focus on that. So the sequelae of diabetes is not really the focus. The focus is surviving so that we can get them through treatment. There has been some discussion of metformin previously because there were some observational studies that said, hey, we think metformin may improve outcomes in patients who have pancreatic cancer, but they did some legit randomized trials that did not show any benefit of metformin therapy for patients with pancreatic cancer, so it is not really recommended. Screening as far as this is kind of the opposite. So if we're seeing evidence of diabetes, should we be looking for pancreatic cancer as an etiology? So pancreatectomy, which seems obvious that this could cause diabetes. If we take out the pancreas or part of the pancreas, we are going to lose significant amount of islet cells and islet cell function, right? So there's a total pancreatectomy, which we'll talk about all these, but total pancreatectomy, you take the whole thing out, there's a 100% chance you're going to get diabetes. You take the whole pancreas out, you cannot not have diabetes, right? If partial pancreatectomy, so you can take the head, you can take the middle, or you can take the ends. And each of these have some different risks associated. They also have different density of islets within them. So you get different risks of diabetes within the different sections that you remove. And then the reason that we remove them are typically some kind of neoplastic lesion, whether premalignant or malignant, acute recurrent pancreatitis, and chronic pancreatitis. So here's the total pancreatectomy. Okay, so there's a little bit of preoperative work that was done here before they made this image, but essentially you pretend like the intestines are all there and normal. And so they went ahead and they remove the duodenum, they remove the entirety of the pancreas and the spleen, right? And then we do a Roux-en-Y. The biliary tract is still present here, but the gallbladder is gone. And so we have the pylorus and the biliary tree are both still present. So there are risks, like you're removing the spleen, which then gives you all the risks of asplenia, right? So you're predisposed to a lot more infection. You need some additional immunizations, et cetera. The loss of that section of small intestine, we know that Roux-en-Y can lead to some nutritional deficiencies based on the things that are typically absorbed in that region. So we have to be more careful about that. And then we also need exocrine replacement, as would be expected. If you lose the exocrine tissue, we need to replace that. So we need to replace the enzymes that we would be getting. So partial pancreatectomy. So Whipple is one of the most common, and we see this most often in pancreatic adenocarcinoma. So here you remove the gallbladder, you remove the head of the pancreas and the duodenum, like the C part of the duodenum that goes right around the pancreas, and then you reattach so that the remainder of the pancreas is still providing some exocrine function, the biliary tree is still intact, and the pylorus is still intact to the intestines. The central pancreatectomy, you take out the section in the middle right here, and then you reanastomose. So you get to keep the whole duodenum, you get to keep the gallbladder, which is hiding here, and then you get to keep the spleen. However, as in all things that we anastomose, it's a little bit risky to reanastomose the ducts together and all of the arterial and venous supply. And a little bit more risky than just doing some like AV stuff, because if the ducts are not appropriately anastomosed and you're starting to bleed like enzymes into different parts of the pancreas instead of the duct, you're going to get autodigestion and lose a large section of that pancreas, right? So ideally, you don't have leakage and you don't have fistulas, and it just beautifully realigns together. And you don't lose all the pancreas. And then distal pancreatectomy. So you get to keep your gallbladder and you get to keep the duodenum with the pancreas head here, but you do lose the end section of the pancreas and the spleen. So you do have that risk of increased infection we see in splenectomies. So what are the risk factors for diabetes after a part of your pancreas is removed? So we talked about total pancreatectomy, like that's obvious, right? We checked that box. But where did they resect? What was the reason for the resection? The more destruction you've had, the less likely you're going to have functioning islets remaining, even if we've not removed the whole pancreas. How much of it did we remove? If we remove 90%, the likelihood that 10% is still going to function successfully is not likely. But 50%, you have a pretty good chance, right? And then what was your preoperative glycemic control? If you already have diabetes based on the level of destruction of the pancreas before we take part of it out, the likelihood that you're magically going to be able to now have improved glycemic control outside of having some adenocarcinoma is not likely. And then chronic pancreatitis, many of those patients develop diabetes before they get to the point of having such severe destruction and pain and symptoms that they need part of their pancreas removed. So it's likely that those patients can develop diabetes. So when we do the partial, the order of risk of diabetes in this situation is distal has the highest, the Whipple or the head of the pancreas is middle, and then central is the lowest. Central, you remove the less, but distal, you remove the highest density of islets, right? So islets are highest in the tail and lowest in the head. And so if we remove the highest density of islet cells and endocrine function, there's obviously a higher likelihood of developing diabetes in that situation. There are a lot of studies that looked at, like, does the sex matter? Does the age matter? Does the BMI matter? And nobody can decide. Everybody has a different idea, but they were all done at different places with different techniques and different all kinds of things. So like, not totally sure. Even some of the review papers are like, well, these people said yes, but these people said no, and they both had 50 people. So how do you know how to decide? So more to come on that. Distal, we talked about the duodenum and pylorus. The loss of those leads to increase in GLP-1, but also some reduced GIP and reduced insulin secretion with decreased polypeptide, pancreatic polypeptide. The median time to onset of diabetes after a partial pancreatectomy is between 3 and 15 months post-op, but actually has been seen up to 5 to 10 years. So there is a degree of long-term monitoring that has to happen. There is a group of people who put together what they call the PDI, which is their pancreatectomy diabetes index. And so this is an evaluation of a patient prior to the pancreatectomy, trying to determine what is the risk or likelihood that they will develop diabetes after they have the surgery. So you can score a total of 8 points. There are 4 points awarded for the highest A1C preoperatively. So if you are greater than 7, then you get 4, and it goes down from there. If your BMI is greater than 30, you get a point. If your age is greater than 65, you get a point. And if you have a distal pancreatectomy, you get 2 points. So when we come over here, okay, you can see that people who had the most points had the fastest conversion to diabetes, right? Some of these people wasted 0 time, and by 2 to 4 months, more than 50% of them had already developed diabetes. If you scored the least points and had the lowest risk, there's a good group of people out to like 10 plus months who still, 90% of them had not developed diabetes. There seems to be this time period. I don't know if they just was a follow-up appointment at 10 months, which like is the reason for this change, and maybe it happened a little bit more gradually. But at 10 months, it looks like we had a significant drop of almost 30%. So about 40% of people at this point had developed diabetes, but it kind of steadies out. So you really are retaining insulin or your islet cell function in about 60% of these patients. The moderate risk score seems to be almost, in the end, it's equal to having a high risk score. It's just that several of these patients are able to maintain some of their islet cell function for a period of time, but by the 15-month mark, they've pretty much all dropped out. So what is the treatment? It's the same. So we use insulin in this group of people because they've lost the ability to make insulin. They also need glucagon because it's similar to your pancreatitis patients, which they may also have been pre-pancreatectomy. They need some glucagon. They also do not tolerate oral medications for the same reason. They need enzyme replacement. And then if your pancreatectomy was for pancreatitis, you can qualify for the TPAIT. If your pancreatectomy was for adenocarcinoma, they are not going to digest your pancreas and put adenocarcinoma cells back into the body. So those people do not qualify for the islet cell autotransplant. However, they have a lower rate of total pancreatectomy. Many of them get partials. And so the likelihood of them qualifying for that and also getting the procedure for it are different. So preoperatively, we should screen for diabetes because we've seen that it dramatically affects the likelihood that we will or will not develop diabetes after the procedure. And postoperatively, we should be monitoring pretty closely. The A1C is helpful once you're like a couple months out, but it's not helpful in those first couple of months where you haven't seen that long-term change, right? You've had a dramatic change postoperatively. We should really be watching our glucoses and OGTTs. If we're really looking to see our islet cells still functioning, are we making insulin? We can use C-peptide levels as well. And then how often you survey and screen these patients after they've had the pancreatectomy is largely based on their risk of developing diabetes. So everyone gets screened for the first 3 months, for the first year or so. And then as they move outside of that window, depending on how likely they are to develop diabetes, they still get screened on at least a yearly basis because there have been people to make it to 10 years post-pancreatectomy before they develop diabetes. The total pancreatectomy was islet autotransplantation. Okay, so here or on the side, this is the pre-surgery, right? So all of the gray is what's being removed. So we're taking this in block right here and then also removing the gallbladder. And then the pancreas is removed and then it's taken to the lab where we digest the pancreas and are able to isolate and purify the islets. The islets are brought back to the OR. There is access to the portal vein is obtained, and then the islets are perfused through the portal vein. If the portal venous pressure is appropriate, the portal venous pressure is monitored very closely because should we exceed an appropriate level of portal venous pressure, we are causing a lot of damage and risk, and we need to move where we're going to put the rest of the islets. So the islets can often be put in the omentum or the peritoneum. Sometimes they're divided. If we can tolerate a certain amount in the portal vein and then we start to develop some hypertension, they will redirect the remainder into the omentum or the peritoneum. These are also, there is a lot of heparin involved in this process. And once they take the pancreas out, you're started on an insulin drip because, you need it. And then it is continued for an extended period of time because these islets are being put in, but they're not expected to function as soon as they show up, right? There's some process to the engraftment, to the revascularization of these islets and to make sure that they're functional. So patients are on an insulin drip for usually several days after the surgery, and also they're on a heparin drip during the surgery and afterwards to prevent any thrombosis in the portal vein, which is obviously very dangerous and would lead to loss of all the islet cells that you have just transplanted. There is significant pain control, right? We've rearranged a lot of the abdomen. So that's a pretty intense part of the management. And then there's a delay in GI motility, I think for obvious reasons. But once that begins, we need to start enteral nutrition with pancreatic enzyme replacement therapy, right? Those have to start at the same time because we don't have any pancreatic enzyme production anymore. There have been some studies. Cincinnati did a couple studies at their pediatric center looking at whether to go from the insulin drip to MDI to pump or directly from insulin drip to pump, and going directly from drip to pump has actually shown to have better long-term outcomes with graft survival. You are on an insulin pump for at least 3 months before they are willing to take you off and test your islet graft function, but you have to prove that you don't need, obviously we would wean down your insulin as your islet cells are showing that they will function. So who gets it? Why do we do it, right? It sounds like a pretty aggressive surgery and a whole lot of moving pieces. The goals of this are really the reason that we do it is the pancreatectomy, right? That's the inciting cause of doing this. If the pancreatitis is so bad and it's causing such debilitating pain and lack of quality of life, then we need to take out the pancreas, right? And if we're going to take out the pancreas, can we keep the endocrine function? Because getting diabetes and having a pancreatectomy at the same time is a pretty severe situation, right? So can we kind of at least alleviate part of the burden of this operation? And so the idea of islet autotransplantation is really cool in that it doesn't require immune suppression, right? You're taking your own islet cells, you're pulling them out of the pancreas that is no longer functioning for you, and then putting them back into a different place with the idea of them functioning as they were previously, but in a different location to prevent you from having severe hypoglycemia and also from having diabetes, right? We know that diabetes is a pretty severe burden to take on in life. In order to qualify for this, you have to have had proof that your pancreatitis is very severe. You have to have failed several treatments, some of which are pretty aggressive and involve surgery, but are not removing the entire pancreas. And typically these people have a diffuse small duct disease that is super widespread, right? Small ducts are pretty much everywhere. And so that leads to pretty widespread and diffuse destruction, genetic pancreatitis, and then failed surgical treatment. Patients who have adenocarcinoma are not candidates to undergo autologous islet cell transplant. So once we do this, how do we determine whether the islet cell graft is functioning, right? So we put them in and that's really awesome, but now like, does it work? Like, how do we decide? When do you need insulin? How long is it lasting for? Is this really working for us? Like, is this extra risk? Because there's a risk of putting things in the hepatic portal vein, right? Like we're putting some extra risk and we want to make sure that this is worth for the patient's function. And so there's 4 different categories. So optimal, good, marginal, and then failed. Optimal, you're able to maintain a non-diabetes related A1C. You do not have any severe hypoglycemic events, and you do not require insulin to maintain that very beautiful A1C. And you also have intact C-peptide production, both in the stimulated and the fasting state. The difference between optimal and good is just that the good have a little bit of insulin requirement in order to maintain their A1C less than 7. They don't require more than 1 per day. They usually typically just require a little bit of basal and maybe a little bit of correction, but not a full basal bolus regimen. And they still have C-peptide production. We start to move down to less functioning. Marginal is requiring significantly more insulin and also has had at least 1 severe hypoglycemic event. Right, so now we're seeing that both the alpha cells and the beta cells are not functioning as well. We're seeing more of a widespread graft dysfunction, but they are still making some insulin. So we know that the graft is having what we consider to be marginal function in that it is making C-peptide, both in the fasting and stimulated states. The failed graft is where we are requiring significant amount of insulin. We're having severe hypoglycemic events, and we are not anymore able to make C-peptide in the way that we would expect in a functioning graft, right? However, these patients with failed grafts don't necessarily have loss of alpha cell function, so they may still have a little bit of protection from severe hypoglycemic events. Not the same as a really good graft function, but still more than just a complete pancreatectomy without any islet autotransplantation. So this study looked at, this was done by a very large cohort of several different universities in the United States, and it looked at surgeries that happened in the early 2000s up to like the early 2020s, right? So keep in mind that there have been a lot of changes in surgical procedures and the way that we optimize patients and have set them up for success. So we see about a 20% loss of graft function in the first year. There have been different cutoffs and uses of inclusion and exclusion criteria over time, and they have become a little bit more strict. So you have to have a certain amount of beta cell function before they'll be willing to actually do the islet isolation and transplant, right? You can't have very poor islet function. And a lot of the way that they evaluate evaluate patients before they are willing to do the islet cell isolation has changed and has improved outcomes. So I anticipate that this will look better in the future, but this is the data that we had when they were able to do this. So you see that you have about a 25 to 30% full function at a year. It stays about the same. So 1 to 5 years, if you're fully functional at 1 year, you're very likely to be fully functional at 5 years. That drops a little bit to about the 20% at 10 years, but still like 20 to 30% is pretty good, I think, at 10 years. And then at the 15-year mark is when we really see the drop of that full insulin independent. The marginal section is the one that seems to move the most from 1 to 5 to 10 years, right? There you start to see that like, okay, I need a little bit of insulin. I need more insulin. Okay, now I'm becoming fully insulin dependent. And then we see graft failure at the end. But there are people who are lasting for 15 years with full islet graft function, which is very impressive. And those are the people that were like, how did we do this for you? Like, how do we do that for other people? There are definitely some pretty significant things that they have learned about islet cell isolation, the yield of islet cells you get. So how many do you get? And then how many do you get when you compare to the size of the person, right? Because the number, like the density is really, if you get like 100,000 for someone who's like 4 kilos, that's very different than someone who's 100 kilos, right? Like those islets have a very different level of production of insulin and ability to maintain glycemic control in those individuals. So we primarily look at islet equivalents per kilo. And some of the things about that, we know that the more you get, the better the more likely you will have longer term insulin independence, because the more you get, hopefully the more that will survive, right? And the more that will be able to function long term. So the benefits are insulin independence, decreased hypoglycemia, and improved quality of life, and decreased opioid use related to the pancreatectomy component. There are a lot of challenges, but it's been really cool to see how far a lot of things have come. We've had a lot more success. There are some interesting thoughts about like how, at what point is the pancreatitis bad enough that you need a pancreatectomy, but the function of the pancreas and the islet cells are still good enough, and there's enough that are still functioning that we're going to get a good islet yield, right? Like, where is that line between the pancreatitis is so bad that it needs to come out, but also like I have enough islet cells that are functioning that I can do this autotransplantation and be successful? It's not clear. I think that's a big work in progress, because young children who have islet cell isolation who need the TPIAT, in those patients, they have the best graft survival, right? Which makes sense because they have the highest functioning islets, they've been alive for the least amount of time, and they've likely had the least destruction. But what they have seen is that in these patients, they get this transplant and their density of islet cells is really great when they're small. And it functions incredibly well until they hit puberty. And then there's a huge change in insulin demand, right? And all of a sudden we start to see that these patients are that their islets might still be functioning. The number that they had at the time of the transplant was totally adequate until they hit puberty. And then that degree of insulin demand increases far more than the islet cells that are still alive and functioning can keep up with. And so that's when we start to see some of the islet cell graft failure, quote unquote. It may not actually have failed. It's just that there are not enough islets that existed to be able to transplant and then mount a response, right? Because as people grow, the pancreas grows, the islet cells develop. There's a lot of interesting thoughts about kind of the timeline of islet development. And is it because, yes, they're really functional, but there's not enough of them? When is the right time or the best time to get long-term good outcomes? There's an instant blood-mediated inflammatory response that happens when you put the islet cells into the portal vein, right? So it's not the same as our like allotransplants that they're seeing in type 1, where we're having an immune response because it's a transplant, like that there's a donor recipient. It's the fact that like, hey, these don't go here, and what are they doing here? The body's kind of like, whoa, these don't live here. Why is this happening? What's going on? How do we tolerate this? And that leads to a pretty significant amount of islet loss, like right off the bat. That creates a decent amount of islet cells that don't even make it to engraft into the liver. And so we have Dr. Bala, who's here. He's one of our, he actually is a world expert in islet cell isolation and TPIAT, which is awesome. I'm super excited to work with him. And one of his areas of research is neovascularization, right? How do we make these islet cells vascularize immediately so that they can survive, right? They need a super heavy and intense blood supply. They are very dependent on that oxygen and the circulation, both to recognize the glucose levels, respond appropriately, and also for like health and nutrition of the cells there. And so if we can improve the way that these cells are engrafted and vascularized, we can overcome a lot of the islet cell loss that we see as they're trying to find their spots in the liver. And then there is a lot of research, and there's a ton of technology. There's actually a couple of companies that are coming out with stem cell derived beta cells and islet cells. And so there's a lot of interesting ideas and ways that we can use these to kind of give like a boost of islet cells, right? So like we gave all the ones that you had, but like this isn't going to cut it. It's going to cut it for 5 years, right? But it's not going to cut it for 10 years. So is there an opportunity to use stem cell derived that are derived from your cells, so you're not going to have an immune reaction or response? And can we like replete them? Can we give you more later so that you continue to have this insulin independence? I don't know. I hope so. It'd be really cool. And they're also doing a lot with the allo transplant as well. So trying to find ways, where can we put them? Are there other places besides the liver? Can we put them in the arm? Can we put them places where we can track them and find them? How can we manipulate this for immune evasion? How can we prevent the this instant inflammatory process that occurs when we put the islet cells in the different places? How can we make it work, and how can we make it long-term, right? Because this would be amazing if it could work for a long period of time. The insulin independence that we could provide to people is pretty substantial. So just a quick summary of kind of what we've talked about today. So there are several different ways that you can develop diabetes from destruction of the pancreas. There are two that I think are really interesting at the top, that you can actually prevent the development of diabetes from the pancreatic destruction by preventing the iron overload destruction of the pancreas, and also by preventing the CFTR related destruction of the pancreas. So those are pretty cool. Pancreatitis and all of the total destruction of the exocrine pancreas in addition to the islet cells, they all require enzyme replacement therapy in addition to insulin and the opportunity for TPIAT in your pancreatitis patients. So you have all survived. I read a lot of papers, and this is your CME code. Any questions? Thank you guys for listening and for being here.
In general, how common do you see the pediatric pancreatitis patients?
In our clinic, not super often. We have some that I've seen in the hospital a few times, but we have not been a TPIAT center, so we don't typically see them. I think a lot of them go to Cincinnati because they have historically been able to.
One of the things is pediatric generally has better outcomes.
Right.
And one of the, even in adult, if they have genetic defects as the cause, alcoholic pancreatitis has the worst outcome in terms of the thing. The issue of how these islets look can be, what they are. It's very difficult to figure that out,
right?
Because most of the studies in any of the pancreatitis and pancreatic diabetes, the number of islets that they would have studied is limited,
right?
And also, technically, how did they identify these different subtypes and all things? Because not all path labs can be able to do it. You would need a highly sophisticated lab to figure out, what's the composition of islets and
yeah, and there are a couple of repositories that have come out, like the IADP has a good amount. There are a couple of different groups, consortiums of islet cell groups that are doing a lot of phenotyping, who are doing a lot of the development of the new beta cell and stem cell stuff, and then NPOT and a few other options that have. So there's definitely more. I was at the HERN conference last week, and there's a ton more that's been done. The number of islet cell projects and the number of donors that we have now with the data that we have is significantly more, but it's certainly not enough. Yeah, and so putting it through flow doesn't give you the architecture.
About the pancreatitis is really depends on what the GI people want.
Right. Yeah.
Because they determine who goes with.
Right.
So there are groups of GI people who do multiple GI procedures before they would recommend pancreatectomy. By which time they have,
no islet cell
diabetes is quite poor. However, the thing is that when we did 70 transplants here with Bala, of course, and so we did not exclude patients with pre-existing diabetes.
Yeah,
C-peptide positivity is all that you need because you will get some islets. However, you may not get too many.
Right.
And almost all patients who have who are even pre-diabetic will need insulin data.
Right.
But the only idea is, will their diabetes be less severe?
Right. And that the risk of severe hypoglycemia is that less severe too.
But that's something that's difficult to evaluate.
Right.
Even because this study which we were part of was between 2015 and 2022 or so. So
that data was from POST.
Yeah, POST is where we have, and the islet outcomes and the diabetes outcomes, we're still writing the paper, so it'll come out soon. Okay. But in those, the results will show people with, it is highly variable. I mean, still the number of islets is the major thing that determines.
We can
outcome.
measure that also.
Okay.
Yeah.
Islet equivalents per kilogram, which in turn you can predict based on C-peptide response, pre-op. But we think that it is not the whole story behind it. Like there is something more to it than just the number.
Well, right, your survival, right? You can start with less. If more of them survive, you can be better long term.
But out there, although on average that is true, we have patients who received few islets and did well, and we have patients who received a ton of islets and did well.
Right.
So whether that was because they had graft failure for a variety of reasons, or did these people have, follow things that are super islets?
Right.
Enough.
I mean, there have been shown in the pathology when we've looked at some of the type 2 patients who some have been on some of the therapies. This was about 15 years ago. We did see some very expanded islets that were substantially larger. Right.
To figure out because we don't have that kind of data. But one thing is some centers have reported a much higher rate of hypoglycemia. Pittsburgh says 30%.
Right.
Of that means people who are insulin independent have significant hypoglycemia.
And I did see that there was a few reports about that, and part of it had to do with is it related to the fact that the insulin is like the hepatic region is so well vascularized, and you're seeing some of the dramatic changes of glucose related to the insulin being released in the alpha cells right there, and is that creating some discordance and some inability to respond appropriately?
But we don't know whether difficult to figure out. I mean, there are multiple mechanisms that's possible. It's also possible that you have, the islet composition is not fixed.
No, and it's not universal either.
It can, you can have what we call transdifferentiation.
Right.
So B cells can become alpha cells.
And alpha can become beta.
Beta cells. So under stress, whether we generated more beta cells than we needed. So that's the thing. So it'll still be interesting.
Yeah, and I think there's a lot coming out. I feel like people are looking closer at different ways to optimize people who are in these settings. How can we do a better job of making sure that when we do these islet grafts that they're working better? What can we do for these patients to make sure that they're in a better state so that the graft survives better and things like that?
In adults, we had some of those other challenges that we don't see in children with the opioids, tobacco.
I mean,
a problem.
which is interesting, like even in some of these TPIAT patients who had 100% like function, they still were like 50% of them were on opiates like so many years later. And you're like, well, versus the kids, definitely.
I think the island was have the palliative pain management person also to treat them well. But I liked your study, the Cincinnati study of converting them directly to the pump, which now is a great idea with all these awesome
with the closed loop systems.
I mean, it's
amazing.
Standard.
Like give them throw an Omnipod or something like that.
Yeah, and that's what they're doing. They created hospital policy, so they actually educated everyone on the unit where these patients go to know how the pumps function and the closed loop systems work, so that they could take them automatically and then do teaching on the pump, so the parents learn pumps from the beginning.
Many of them, your Beth would see them ahead of the system, train them how to use it.
Which is also perfect. So it's definitely been pretty awesome between the. Okay.
It's a very informative talk, Emily. I hope you can hear me.
Yeah.
Okay. So in the literature are informations available related to how many CFTR patients they leads to this diabetes development. Similarly, like pancreatitis patients, they leads to development of diabetes. Those informations are available in the literature and all, Emily. Hello.
So by the time they're in adulthood, it's similar. So in the CF patients, also, hi, Bala. Thanks for joining us. I'm super excited. The CF patients, 20% of them during adolescence. So there is a higher rate of diabetes in the CF patients during adolescence because there's more common in our pediatric patients than pancreatitis is. But by the time they are well into adulthood, the CF patients have about 50% development of diabetes. The pancreatitis are somewhere in between, but people who have genetic pancreatitis are generally 60 to 70%. So the pancreatitis patients in the end, I think, win out having a higher rate of diabetes. Also, the new modulator therapies for CF are showing some improvement in the glycemic control earlier on. And so I think that we will see less and less of the CF patients having diabetes in the long run.
And then the mechanism of diabetes development, is it primarily because of the ductal occlusion leads to exocrine autodigestion, or any other kind of inflammation, because the exocrine cells are dying, maybe more inflammatory cells are coming? Is it the mechanism of type 3C development? Is it kind of described?
So is it from the ductal plugging? Is that what you're saying, the destruction of the parenchyma?
I see. Okay.
No, I'm trying to clarify. Sorry. Is that the question that you're asking?
Yeah. The mechanism part, really, I don't know the mechanism. Like, is it primarily because of the ductal occlusion or any other inflammatory reaction going on because of the disease condition?
So it's a combination. Both of those play a role. The ductal obstruction typically starts to kind of precedes the process of the autodigestion and also leads to a lot of the inflammatory process, right? Because that's where the damage is starting, is related to the ducts. We see that in both the CF and the pancreatitis patients. However, the CF patients also have some internal destruction of the beta cells related to the membrane transporter that's not functioning properly, versus the pancreatitis patients are almost entirely related to the destructive process that takes place related to like the fibrosis and inflammation surrounding the ductal occlusion and autodigestion that takes place.
So then Dr. Swami would have some idea about the CF patients. How many of them have diabetes?
Sorry, I missed the question.
Yeah, so in CF patients, it's about 20% in adolescents have developed diabetes and about 50% in adulthood.
In adults, it's higher as they grow up.
But I don't think the Trikafta has made any difference.
So Trikafta, interestingly, the studies are very sort of contradictory to each other. Of course, Trikafta increases your BMI, sense of well-being. So we're seeing a lot more metabolic syndrome, obesity, insulin resistance.
Interesting.
In the adults.
Yeah.
The point that some of them are not transplant candidates. Of course, the transplant has gone down since
because the pulmonary function
starting around pandemic 2019, then the transplants have gone down. So certainly, and then there's a newer one also coming to market. So certainly it's made a difference. But when you look at the group from Harvard and then from Yale, Melissa, I keep getting a last name. So they've done most of the studies.
Yeah.
It's been contradictory, whether it's improving the health of islets and improving overall diabetes because of this with the.
So even if you improve the islet function and like the lack of destruction surrounding it, you may be getting like a type 2 diabetes, really though, like you're getting a different phenotype.
Lines are getting
higher.
Patients are feeling great. There's more pregnancies, fertility has gone up. So Trikafta has made an amazing difference, but then bone density did not improve in our study that our former fellow that presented the data at the Endocrine Society.
Right.
So it was interesting. We thought everything is going to change and I probably won't be as busy as I was before in the adult CF clinic, but that's not the case.
Which is so interesting. And also because we work so hard to get them to gain weight in pediatrics, right? We force feed them anything you'll eat, please eat it. Like just eat anything all the time. And then they're better and they're like, I can eat all this stuff. And we're like, no.
Now
you work again. Like you need to back off on that. That's really interesting. So we're pushing them over the edge.
Looking at their body composition,
Yeah.
body measurements now in adult groups, and we'll have some more data available.
That's super cool.
The other challenge we have is with the gastroparesis that happens also along with their pancreatitis, like exocrine, and then also some of the reactive hypoglycemia that you see as part of the dysglycemia,
Right.
which is all very unique to CFTR.
Yeah.
As I want to see the active hypoglycemia pancreatitis.
Yeah, other as opposed to the other 3C.
Yeah. Well, because the destruction is different too,
Yeah.
which is really interesting.
So,
and
Iowa has the parrot model of the IMS, and they've done a lot of the studies.
have they?
Very interesting, yeah.
It's super interesting. Yeah. When I was working for NPOD and grossing tissue, we got a couple of donors that had cystic fibrosis. And it was really interesting. You get their pancreas and it looks it's kind of like lumpy fat, but if you touch it, it actually just disintegrates. It's all fat deposition and just some like scattered islets around there.
The bones are different.
Yeah, their pancreas is it's literally like butter. It's lumpy butter and it disintegrates like
as
butter.
Opposed to the
regular pancreas is more tough and it's like you could throw it around and it would be fine. Yeah. And this one was just like it would melt.
Gastroparesis is also a problem for the pancreatitis patients.
Right.
Which
complicates
because the problem is that they post-operatively they have a lot of issues related to that.
Yeah.
Weight loss, nausea, vomiting.
Yeah. That's great. That was a great overview.
Thank you. Thanks, guys. Appreciate it. We all survived it. That's awesome. All right. Thanks, guys. Appreciate you.